So my name is Ajai Chari from UCSF, and happy to take any questions. This is always the fun part of myeloma, getting to talk to patients and caregivers. So I think it's intended to be open format, so if anybody has any questions.
I think it was Dr. Costello's talk. She talked about MRD. What is indicated when you have no cancer cells observed and yet you still have activity on your biomarkers like the light chains and the monoclonal protein?
So there could be a couple of reasons for that. So one reason is sampling issue, right? So when you do a bone marrow biopsy, if let's say you got predominantly blood, it wasn't a juicy. By juicy, I mean when you suck out a bone marrow, you should see a lot of fat particles. And if you take too much liquid out, you essentially get blood. And so then if you're not getting a good sample, that could be why you have an MRD negative sample, but still myeloma in the blood. The other reason would be what I call macrofocal myeloma, which is we have patients who have discrete spots of myeloma throughout the body, like on scans, they'll show up. But if you do a random biopsy, it doesn't show up. And it's kind of like it's analogous to what our solid tumor colleagues treat, right? Like breast, lymphoma. Those patients tend to have discrete pockets of disease, but not necessarily throughout uniformly in the bone marrow, like say some other blood cancers are. So those would probably be my top two reasons.
Would these discrete pockets show up on a PET scan? And
they should.
Might help guide biopsy targets?
Yeah. Oh. And that's why I think it's important because people focus so much on MRD, but what did the FDA say? The FDA said that in a randomized clinical trial, you can use MRD as a surrogate endpoint. That means that it's an early readout, but it still requires a confirmatory progression-free survival. And what people don't realize is when you sit in a clinical trial, you don't go straight to the bone marrow, right? And so any of us that have sat on committees, so you may or may not know this, but when patients are in clinical trials, there's physicians that are involved in the review of the data that have nothing to do with the study. They're considered independent observers. And you're looking at each month at the blood, the urine, imaging, all the labs. And so why I bring that up is that before you go to a bone marrow, you have to check the SPEP. SPEP should be negative. Immunofixation should be negative. Light chain should be normal. Urine should be negative. Then you can go to the bone marrow. Because if it's anywhere else already detectable, that marrow could just be a false result, like you're saying, right? If you have other disease elsewhere, the marrow MRD negative doesn't trump the blood testing or urine testing. Yeah, there's another question. Yeah, I think the question is if you have positive disease by M-spike or light chains, why do the marrow? I completely agree. I tell people, there's one exception I'll get to in a second, but in general, if you have myeloma in the blood or urine, why do you want an invasive procedure to tell you what you already know in the blood, right? The one exception is that we now have immunofixation positive patients due to not disease, but due to therapy. So what do I mean by that? Patients who are getting monoclonal antibodies, typically drugs would be like daratumumab, isatuximab, all the bispecifics. They typically tend to be IgG kappa myeloma with one exception, teclistamab is IgG lambda, but all of those can show up in the blood as a positive immunofixation, and if that's the same type of myeloma that you have, you need a little bit more sophisticated testing to tell whether that's the drug or the disease. And luckily we do have that. We have a test called mass spec, which can help us tell whether this positive result is due to your myeloma or the drug. And if that's negative, then that would trigger a bone marrow. But you're absolutely right. Why do an invasive, painful procedure if you don't need it?
But if your light chains are elevated higher than it should be, you still would have to do either the mass spec or.
Yeah. Well, this is like myeloma 201, not 101. So there is another example of that. In general, you're right, but if you take a healthy person who has, let's say, one kidney or has some kidney damage, but no myeloma, those patients will have a slightly higher kappa than lambda, and it has to do with how the body processes these light chains. And in fact, recently, many hospitals have updated the reference range for light chains for patients with chronic kidney disease. So that would be the one exception where if somebody has chronically elevated kappa relative to lambda, we're not talking about hundreds, just a little bit above, and it depends on the units, but let's just say the ratio is around 3.5 or less, that could be from just kidney disease. But if you're like 10, 20, 100, 300, you don't need a marrow. Oh, this is going to be a tough one.
Actually, no, it's not going to be tough. Actually, this is from somebody who couldn't attend the meeting but wanted me to ask a question. They had CAR T-cell therapy, and now they're not relapsing yet, but they're trying to think ahead. And they wanted to know if CAR T-cell therapy can reset your myeloma so that you might be now, again, responsive to drugs that you were previously resistant to, like daratumumab.
It's a really good question, and we really need to study this formally. I think part of that is it probably depends on how long the remissions are lasting. One good thing that I think this data will be coming out at this year's ASCO, but many of you know cilta-cel or Carvykti. And when at my previous institution in New York, we actually had about 30 patients on that study. And what was really so rewarding is a lot of those patients are still in remission. And it's years out from the CAR T. Not just 1, not just 2, not just 3. We're like talking 5 years out. So that's really encouraging. And I bring that up because I think the further away you are from that initial CAR T, the more there may be a reset, right? Because you've been so off therapy, your immune system's recovered, and maybe even the myeloma, if it does come back, might be different. So I think that's probably one factor. The closer the relapse happens to CAR T, I'm not sure there will be as much reset. And I think the other thing that we're now understanding with sequencing is, so to answer one part of the question, you could go back to the conventional myeloma drugs, like let's say Revlimid or pomalidomide. You could potentially go back to those if it's been a long time. The one thing that we're now appreciating with sequencing is it does seem to matter. So for example, if you give CAR T first, and I think this is in my talk later this afternoon, but if somebody gets a BCMA CAR T like cilta-cel or ide-cel, and then they get another BCMA-directed therapy later, like a bispecific, there does seem to be a negative impact on the remission duration. People will respond, but the durability may be compromised. So there's like different types of reset that we think are happening. There's immune and tumor resets that we need to think about.
When Dr. Costello presented, it looked like cilta-cel might be a little bit longer duration than the ide-cel. Is that your experience?
I never disagree with Dr. Costello. We're always taught in medical schools not to do head-to-head comparisons, and the reason for that is there's always patient selection differences in single-arm studies. But again, this is a myeloma 202 question, because we now have, I would not have compared directly head-to-head the single-arm studies, because let's just say you got much sicker patients on one and much more heavily treated. That could account for slight differences, although even there, it's hard to say 80-something% is not different than 98%, and 1 year is not different than 3 years. But now we can put this into a little bit more context, because we have randomized phase 3 studies where each CAR T was compared to standard of care. And so what we now know is ide-cel had a remission, say, of a year, and the control arm was only 4 months. These were very sick patients, so the control arm's remission was quite short. So the value add was maybe 50% in terms of what we call the progression-free survival. In cilta-cel or Carvykti, the remission duration of cilta-cel we don't even know yet, but the control arm did even better than the other group, the other study. It was 1 year. So these are better patients, not as beaten up. And despite them doing better, we think that the value add of cilta-cel or Carvykti is 75%. So when you put all that together, I would say that cilta-cel or Carvykti is showing a more profound benefit even with healthier patients than ide-cel did with sicker patients, right? So it should be easier. If you're in a track race, ide-cel had really, their comparator group was pretty easy to beat. And they did beat it, but not as much as cilta-cel blew it out of the water, even though their competitor was quite good. But the ideal way to answer your question would be put ide-cel versus cilta-cel, which no one's ever going to do. We don't. That never happens unfortunately in oncology, or rarely does that happen in oncology, but this is the best information we have. The one thing I'll say though is that there are some side effects that we don't see as much with ide-cel, right? Like we don't see as much Parkinsonism, we don't see as much secondary cancers, lowering of blood counts, but the remission is shorter, so it's a trade-off.
We've talked a bit about MRD negativity, and I know there's a debate on how hard do you work to get there. And I've seen a presentation from Dr. Pavia about this MGUS-like state. Can you make a mention about that?
Yeah, it's a great question. Sometimes when we get rid of the myeloma, when we treat people with myeloma, we're able to get rid of the myeloma that caused the CRAB symptoms, right, calcium, renal, anemia, and bone. But we may be left with a little bit of disease, and one of the questions is that disease important or not to the patient, right? The analogy I always use is like MGUS and smoldering are like moles on your skin. They don't cause a problem, but they're never going to, they're there all the time. And do you need to hack out every part of your body to get rid of that mole? Or if it's really melanoma and you need to get rid of it and real myeloma. And I think the problem is when you put them together, it's hard to tell. And one way that is not yet well validated globally, but the Spanish group, Dr. Pavia, is using flow cytometry to characterize whether that residual small amount is myeloma or not, is that MGUS clone. And one clue to that would be, well, there's two clues I would use until we have that assay validated. One is, does this patient have a antecedent, meaning pre-myeloma precursor disease? So if somebody had MGUS and smoldering, and then years later they went on to myeloma and start therapy, that patient I would worry about maybe there's a little bit of MGUS clone remaining. On the other hand, if somebody's very high risk myeloma, I would not presume that that's just an MGUS clone, right? Because high-risk patients, you really want to try to drive them to MRD negativity if at all possible, because those patients, we know that even MRD negative is not sustained, let alone if you're MRD positive. But short of those two extremes, we don't have a lot of information yet. Yep.
Okay, I've been seeing some chatter on social media, I guess at the conference that was just in Honolulu, that these chiro caps could, during stem cell transplant, could help with hair loss. But the question I have is, I've heard doctors in the past saying that they wouldn't recommend these caps on your head during melphalan because there's a possibility that you might not get some of the myeloma cells that might be up there in your skull. So what's your opinion on that?
Yeah, so we actually have had this at UCSF. A handful of patients have gone through this. So the principle here is that cryotherapy diminishes blood flow, right? So when you have swelling on your arm, you put ice to decrease the swelling, that decreases the blood flow. One of the benefits of decreasing the blood flow is you might decrease drug delivery to areas that you don't want. So many of you might have done, for example, ice chips during the melphalan chemotherapy. That decreases the blood flow to the mouth. So the principle is if you put a cryotherapy hat, which is a cold hat on the skull, are you decreasing melphalan and toxic drug delivery to the hair and thereby decreasing hair loss? And so far, we have our great nursing team. They'll be writing this up. I think 10 out of 10 patients have not lost hair at UCSF doing that. So this really should, I think, be used more liberally. There was one patient where there was a skull relapse. So this brings up the question, well, if you're decreasing drug delivery, are you then now allowing myeloma to remain in that parts of the body? My guess is I don't think so, because I think melphalan is such a whopping dose and it's distributed everywhere. That patient didn't have relapse only in the skull, right? It was other places of the body too. And this was a high-risk patient. So I think to really answer this question, we're going to need larger data sets, and we don't want to be practicing anecdotal medicine like, oh, I heard this person and that person. But I think if the data pan out, this could really change the nature of the transplant.
Well, speaking of anecdotal medicine, I have an anecdote I'd like to give you to see what your reaction is and what I might do with it. I'm a 6-year myeloma patient, and the last couple of years I've been experiencing a lot of drag, slowing, moving my body around, just everything takes more effort, and it's slowed me down, and that's, of course, had various secondary knock-on effects. And then recently, just 15th of February, I started dosing myself with, after the approval of my oncologist, I dosed myself with creatine because I'd heard it might have some beneficial cognitive benefits for older people. So I was expecting, subtle, long-term results, if any effects from that would be long-term, and maybe in a month or 2 or 6, I might see something happen. But that's not what happened. Within 2 days, I had a spectacular result where I was trying to do something for chemo brain, but I ended up curing my chemo drag, if you want to call it that. And ever since, I feel like a new man. I've just been revitalized. And that prompted me to study the mechanism of action for creatine, and knowing the mechanism of action for Velcade, proteasome inhibitor, it makes perfect sense to me. But I'm a layman, I'm a neophyte. But I just want to know where to go with that. It's like, maybe it only works for people that are on my particular combination of medications, but if it works, then that's a very standard combination that anybody can benefit from.
So I think, I'm thrilled to hear you're feeling better. I think that's the first and most important thing. And, without anecdotes can lead to major scientific discoveries, right? So for example, many of you may know that the IMiD category of drugs, thalidomide, lenalidomide, pomalidomide, was all due to advocacy of a patient's caregiver, right? So there was a patient who had very limited remaining options. I guess this is now back in the late 90s. And his wife researched and found that there was some work being done in Hopkins on thalidomide and blocking blood vessel development. And so she lobbied for his doctor to get that open at Arkansas, and the drug didn't work for him, but amongst the first 10 patients that were tested, there were several responses. So if this one person had not advocated, because no one was studying that drug in myeloma, it was her advocacy because she saw that this connection. So anecdotes like this can be the initial spark for some major scientific revolutions. And so had she not done that, there's $1 billion market that would not have existed, right? But on the other hand, side effects and benefits can come from patient, disease, or treatments, right? So that's really important. Why do we need clinical trials? Because whether good or bad, whether myeloma is gone or they're having a lot of side effects, is it because of the patient? So age, other medical problems, such as heart problems, kidney problems, the disease. So for example, let's apply fatigue. So age, other like heart failure, kidney failure could affect fatigue, disease, anemia could affect fatigue, kidney function, and pain could affect fatigue from the bone disease, and of course treatment, right? The dose of the drug, which drug, that could affect treatment. So it's hard to say from a single patient what variable was the problem and what's the solution. That's why we need large groups of studies, and by randomizing them, we think medically that the likelihood of imbalance will be minimized so that you can isolate out the treatment effect, right? So if you take enough patients and put them in both arms, you think that the patient and disease components will be adequately balanced and you can isolate out your treatment question. So it's great that you're feeling better. I think the last point I'll make, which I'm sure Dr. Kwok is addressing too, supplements and diet is great. My only 2 points on that is it's, of course, eat a sensible diet, and be an advocate and look up things, but don't assume that you can control. Some people feel like all myeloma can be controlled by diet and supplements. And if it was that easy, you wouldn't need all these drugs. And then the second point I would make is that sometimes, my mom has a PhD in math and she hates any medication. But any supplement, she'll just pop it in. And the problem is that in the laboratory, there's a lot of great examples. Green tea, vitamin C, resveratrol, curcumin, all showing benefits of killing myeloma. But the problem is in a human being, what dose of that supplement do you need to achieve that level in the laboratory? And what's the safety of that? And how does that interact with your other medications, right? So it's more complicated. So I think importantly, you feel well, and we'll all have to learn more about creatine. Yeah.
What diet do you recommend for a myeloma patient?
Which diet?
Diet.
I think nothing. I think just a general well-balanced diet. I think the only myeloma-specific things would be, if you're prone to high sugars, avoiding sugars because of the steroids that are used. But there's this whole down with DEX push movement that's happening in myeloma. So hopefully that's not a big thing. And I think we know, for example, those supplements that I mentioned can be helpful, but high doses of vitamin C have been shown to interfere with drugs like Velcade and carfilzomib. So if you're getting those drugs, it's okay to have vitamin C, but not supplements. And other than that, I think just a general well-balanced diet. There's some early data, I guess, again, I'm curious if Dr. Kwok is addressing that maybe plant-based diets are better for cancer and prevention, but I think we still need a lot more data, I think, before saying, yeah, give up everything. Because I think, especially, some of the therapies are so, I worry about patients who are so austere with their diet that they're losing weight, they're not putting on muscle, and to what end, right? Because it's like if you're pre-transplant, post-transplant, on certain bispecifics, it's important you maintain your weight. I'd rather you eat what you can to maintain your weight and muscle mass rather than being really stringent about a diet that may or may not actually help with the myeloma, right?
Thank you.
Yep.
I have a question on the CAR-T. Other than insurance companies, is there a restriction on age?
Yeah, we're trying to move away from age in general in oncology, and it's really, so this field of geriatric oncology, as the population ages and as the doctors age, the cutoff changes. But I think in my presentation, I'll show that I think if you did a bullseye, transplant is the smallest dot, CAR-T is bigger, and bispecific is even bigger still. So I think many of us feel that there are a group of patients who may not be perfect for transplant, but do very well with CAR-T. And so in general, CAR-T I think is more liberal. But the key question with CAR-T and age, I would say the two things I would want to know is, number one, is this patient, can they tolerate a high-grade CRS, right? That's really the main, because unlike bispecifics, when you put in a CAR-T, those T cells expand and you can't control it. Whatever happens, happens, and if that causes fever, low blood pressure, you have to make sure that the patient can tolerate that, right? Because this is basically a physiologic stress test. So if the patient can do that, like if somebody's walking a long distance, has no heart problems, I think you can easily do a CAR-T. But if somebody's barely getting by, that's one thing, is like the ability to tolerate high-grade CRS. And then the second thing would be some of these neurologic side effects, right? So if somebody already has unsteady gait or has Parkinsonism or has some central nervous system disorder, I might worry a little bit more. And of course, some might say, well, why not do the question about ide-cel? I think some centers do ide-cels for older patients, right? And just because you don't have to worry about that high-grade CRS and neurotoxicity. My pushback to that is, if you did a head-to-head study of ide-cel versus a bispecific, I'm not sure that ide-cel would win, because the CAR-Ts are extremely cherry-picked patients, right? So I can tell you that when the first CAR-T studies were done, each center would get one slot. And it was ridiculous the kind of things we had to do, because at Mount Sinai, we had, say, 10 physicians, right? And you get one slot per month. And it was like, okay, well, I have a 60-year-old, I have a 50-year-old, I have a 30-year-old with toddlers, right? And my patients got stable. So there was so much cherry picking in who got to sign the consent, let alone who actually got to the CAR-T. Bispecifics have none of that. Anybody who's eligible goes. There's no, you have to be stable, collect, manufacture. And so I would say, in head-to-head study, if the bispecifics are given progression-free survival of 1 to 1.5 years, I'm not sure that ide-cel's 1 year would cut it, right?
The other question I have is, when you talk about success rate, what is the duration of time where they're measuring success rate? Is success rate you get an immediate response and you're doing well, but 2 months later you're not? So where does that success line, how do you measure success is what I'm asking.
Yeah, it's a good question. And this is what all the health authorities always struggle with, right? Because there's, especially, with who knows what the FDA's staffing will be like, but their job is to show that drugs are safe and effective. So the number one thing would be survival, right? Are people living longer? That would be great to show. But the problem is that it's hard to show in diseases like myeloma, because there's drug A, then B, then C, and if you don't respond to that, you can get this. So it's getting harder and harder to show that, but at least we should see lack of harm, right? We don't want to see more people dying of a therapy. You may not be able to show that people live longer because of a therapy, but that would be overall survival. Next comes progression-free survival, which is how long does the myeloma stay in remission without calcium, kidney, anemia, bone, or the myeloma numbers going up. Then comes response rate. Does your myeloma numbers drop? And usually we're looking for at least a 50% drop. That's called a partial response. Less than 50% could be meaningful to some patients, but that's not historically met the cutoff for what we consider a response. And then, of course, within that, people are also now scrutinizing complete response and MRD negativity, right? Because if you're getting responses, and even if it's not necessarily that many, but if a few patients are getting very deep responses, that may be also an interesting signal. But basically, it's response, progression-free survival, and overall survival are the main ways we show effectiveness. And it's very important, and your question is really a good one, because more important, especially in the T-cell redirection era, it's not responses, it's PFS, right? It's not, because for example, if you give a bispecific after another bispecific, you'll get a response, but the duration is much shorter. So what we want more is always, time-based endpoints always are more important than responses, right? To your point, you don't want just a transient, you want it to be durable.
Thank you so much for being here. So I have a question about bones, and it seems like we're talking about drugs and, like you were saying, the success of just not dying from the multiple myeloma. But then you have, osteoporosis and trying to strengthen the bones. And then, like what the other lady asked about food, when I talk to my doctor, who's a lovely person, he's so data-driven that I feel like there's this part that's missing, that it's a human being, me, on the other side. And we have to, I feel like there has to be like a wellness advocacy person to go alongside the doctor, because he's talking about data, which is great. But if my bones are so weak that I can't have the kind of life and quality that I had, hiking, I live in Marin County, so hiking, Tennessee Valley, or going scuba diving, or doing these things, that's not a good quality of life for me. So. Yeah. Do you see anything in the future talking, because nutrition is really, really important, and when I talk to him about it, he just says, whatever you can eat is great, and it's so vague, but there has to be something else.
Yeah.
Wellness, stress, meditation, Ayurvedic, there's so much, and yet it's never mentioned, and it's super frustrating for me as a patient.
No, I think it's a really important point, and I think more and more of oncology, as myeloma has become more and more of a chronic disease, we have to deal with these what we call survivorship issues, right? And I've noticed that the younger the patients are, the more this is a challenge, because our older patients are used to having blood pressure medications and cholesterol and this and that. The young patients are like caught off guard by this life-altering diagnosis. Then they have to cope with that. They do all this stuff. They go to transplant. And then when you start talking about maintenance, they're like, what do you mean maintenance? I thought this was it, right? And the older patient's like, okay, fine, maintenance, right? So I completely agree. I don't know that, I think this is where you need multidisciplinary help, right? It can't just be physicians. It does nurses, social workers, therapists, everybody. But I really, in fact, just yesterday I sent Jenny an email. I have a patient with myeloma from New York, and she's in remission, and she's a physical therapist, which is such a unique skill set, and you never hear about this. And I think she really, great, another therapist. But there's so much to talk about with activity and physical therapy. And so one thing I would like to see more discussed actually is the height loss. So many patients lose height and no one talks about it, right? Yeah, and so can I just get a show of hands how many people have lost height coincident with myeloma? Look at that. And yet it's never talked about, right? And I'm very curious about that because it also, that has some impact on the body, right? So the ability, if you lose several inches, it restricts your lungs' ability to expand. So that's one major problem. The other things that I wanted my therapist patient to talk about would be orthostatic hypotension. So a lot of patients, so this could be another cause of fatigue. We always do vital signs sitting, but then you're fine. And then when you stand up, you're lightheaded and woozy. And so people never check vital signs. And there was a Dana-Farber study that showed that the likelihood of orthostatic hypotension in transplant is 70%. because people are not eating and drinking. They're having nausea, vomiting, diarrhea. They're on multiple blood pressure medications, and they lose weight. So that's a second thing. People are not moving enough, right? Like my name in Epic, the electric gets auto-corrected to chair, and everybody gets frustrated, but I love it because whenever I'm in the hospital, I'm like, why are you in bed all day? You're just here for monitoring. Get in the chair, right? Like, there's no reason for you to be in bed all day just because you're in the hospital. I don't know why there's that myth. And the more you stay in bed, the more debilitated you get, right? And with some of our drugs like IMiDs, the more clotting you have. When it comes to bones, I'll tell you, like in my note, I have my little OCD template. So number one with bones, first thing I have is imaging. What was the last patient's imaging? When are they due next? And sometimes I switch the modalities. If they do PET, sometimes I'll switch to MRI or vice versa because I want to check that both modalities are capturing disease. So it's a general rule. I think in the beginning, it's good to check at least annual imaging, but if you're extramedullary disease, every 3 months. Next, I like to check bone density at baseline because I want to know how bad is this patient's bone density. There's studies that show that even MGUS and smoldering myeloma patients have a higher incidence of osteopenia and osteoporosis than aged matched controls. So I don't keep doing it. If somebody's normal, I don't worry about it. But if somebody has osteoporosis, I want to keep doing bone densities to make sure that I'm hitting all the parameters. The next is bone strengthening drugs, everybody's favorite, right? Zometa, Xgeva, making sure you get dental clearance and making sure you get those treatments. Vitamin D level needs to be kept up, especially if you're on Xgeva, because that drug's black box warning is low calcium, so you have to take vitamin D. Then there's activity restrictions, right? Unfortunately, again, I think it may take a physical therapist to do this study, but I would love to see a study as to what is safe once you've had compression fractures. What amount of weight can somebody safely do? We just err on the side of caution and say that if you have bone disease and have had compression fractures, try to not lift more than 10 to 15 pounds, because any of you who've had a compression fracture know that that can be exquisitely painful, and I think it's better to be preventative and cautious. You can do light weights, but don't go crazy. For pain, avoid Motrin, Advil, right? We prefer Tylenol. So those are some of the things that we can do, but the way we help bones are controlling the myeloma, strengthening bones with bisphosphonates or anti-resorptives, vitamin D, physical activity. It's got to be all of those pieces, but then also moving. One of the things I always ask my patients every visit is how much can you walk without stopping? And you have to have an intentional effort to try to increase that, right? And some patients, and that's one of the most rewarding things I would say of myeloma, is that I've had patients come in a wheelchair, and within a few months they're back on a treadmill. And very few diseases have that kind of an improvement, so it's incredibly gratifying. But I think hopefully the mental component of this is something that we don't have time in oncology, short visits, because we have to go through myeloma, bones, kidneys, all infection prevention, all of these medical things. And that doesn't mean that the mental health isn't important, but it needs to be supplemented elsewhere.
Yeah. Do you have a recommendation for sequencing between CAR Ts and BiTEs? And can BiTEs come back more than once?
Yeah. It's funny, I'm giving a talk in Brazil next week, and this company purposely did not want me to present the data on sequencing because let's put the caveat. We have very limited data currently because if you remember that bispecific and CAR Ts started clinical trials in 2016, 2017, and what that means is that all the sequencing data is currently limited by the fact that patients who went from one to the other were probably the worst patients, right? Like the people who had bad disease, whose myeloma relapsed, are the ones who are going on to other therapies, because my patients who got cilta-cel are in remission for 5 years, they haven't gone on to anything else. The people who relapse in 1 year are going to go on to something else. So that's one caveat. And the second caveat is that bispecifics currently are being given at full intensity regularly until progression. And that's how the initial clinical trials were done. And that's not a criticism. It's because we came from a place, one of the most gratifying things I would say when I left New York to move to San Francisco and I was saying goodbye to my patients, I'd been in New York for 18 years. Many patients, we had hospice discussions, and they ended up being in stringent complete remissions, right? Like, what do we know? We don't know. But at that time, when bispecifics were first coming out, and this overlapped with the COVID pandemic, we were very concerned about holding a drug because you were taking people that had exhausted every therapy and they were now responding, and historically, you couldn't hold a drug without letting the myeloma go back. So I mentioned those two caveats because it may be very different in the future if you give less frequent bispecific, or you stop a bispecific, because that might really change how you sequence. But with those two caveats, what do we know now? If you do the reigning queen in myeloma is cilta-cel with a 3-year remission duration, right, that Dr. Costello, I'm sure, talked about. If you get a bispecific before that, that drops to 5 months. That's a big drop. So I think currently we say no bispecifics prior to CAR T. And particularly what I'm talking about, we should drill down a little bit further, because we kind of just say CAR T, but really there's what we call, the new terms we're using are bridging therapy and holding therapy. So holding therapy is when a local oncologist is like, you know what, you might be a good CAR T candidate, I'm going to refer you to an academic center. That holding therapy is how do you keep that patient controlled till they actually go through the CAR T authorization, T cell collection. Once the T cells are collected, now it's called bridging therapy, because the T cells are already sent off, and now we can be more permissive. So in that pre-T cell collection, probably it's good to avoid all therapies that could affect CAR T. So that would be including bispecific and also the antibody drug conjugate. Belantamab, many of you may know, Blenrep, that drug also compromised Carvykti's PFS. It went from 3 years to 9 months. So I would say if you're going to CAR T, try to avoid those things. However, we now know that you can give bispecifics after the T cells are collected. We don't have long-term data yet, but those seem to be safe. Talvey or talquetamab has been used in about 80 patients in a data set that was presented at ASH, and those patients got it after the T cells were collected to control their myeloma. And the reason that's important is we know that CAR T's safety will be greatly determined by how much myeloma you're going into it with. So if that's your only option, use Talvey to try to keep the myeloma under control so that you get a safer CAR T outcome, right? Because everything with CAR T is better if you go in with less myeloma. Less CRS, less ICANS, less neurotoxicity, less blood count lowering. So all of those parameters are better. So basically, CAR T if you can, and then what happens after CAR T? Then you can go to bispecific, and what we now know is maybe better to switch classes, because when you go from a BCMA CAR T to a BCMA bispecific, it does seem to lower the remission duration, and I'll show you data in my afternoon talk. And whereas going from a BCMA CAR T to GPRC bispecific does not seem to have as much negative consequences. But that's the extent of the data that we have right now, but we really need more banked specimens. We need to study, because we need to study, as we were talking about earlier, both the myeloma and the immune system, because the myeloma may not change, but the immune system could be the problem. And so we may need to also think about putting in non-T cell redirection therapy. So maybe we need to do CAR, and then some other kind of non-BCMA therapy, and then go back. So we have to think about all of these sequencing, which we never had to before. So it's a lot of data needed. Sure.
So we've looked at these trials, and we know that due to eligibility criteria, it might not represent the patients that actually are going to be using these drugs. But you have an immunotherapy consortium, and you're looking at a lot of these drugs in your UCSF patient population. Are you seeing the same things in your real-world experience through that real-world database that you're seeing in the clinical trials? And then similarly, just speak to the relevance and the importance of providing consent to participate in real-world evidence. A little setup
The last
for Jenny.
one is super easy. Every advancement in myeloma to date has been possible because patients like you have participated in clinical trials, right? Otherwise, we would have never made this progress. So every advancement requires clinical research. So that's a no-brainer. Everybody should participate, and you could be giving data, or it could be in a clinical trial. All of that is important. Depending on the data set you look at, up to 40 to 50% of patients, real-world myeloma patients, are not study eligible. It tends to be because of age, kidney dysfunction, blood counts, other medical problems like heart disease. So this is a big problem. And so that's not a criticism of clinical trial, because if you do a clinical trial in very, very sick patients, you won't be able to isolate out, is it because these patients were sick, or is this a toxic therapy? So we need to do these studies as we were doing them. Maybe I would like to see a cohort of kidney failure patients and older patients within these studies so that we can get them better represented. But what we're seeing so far is CAR T does seem to work very well in real world, but perhaps not as well as in extramedullary disease, and also a lot of the real-world CAR T patients have had prior therapy. So going back to our sequencing question, that's been one of the limitations. The bispecifics seem to be doing pretty well compared to what the study, and I can tell you that, when the drugs were first approved, the bispecifics, and I was at Mount Sinai at that time, who were the patients that got them? Because everybody that was study eligible was already getting on study. So when the bispecifics got approved, it was the heart failure patients, the kidney failure patients, the dialysis patient, CNS myeloma patients, and guess what? They all did fine, right? And that's the beauty of a bispecific, because you can always stop the drug. If there's a side effect, you let it recover. CAR T, you have to really, it's like training for a marathon, got everything in place, because once you give the CAR T, you can't take it back. It's going to expand and do what it does. So that's the big difference between the two. Yep.
I just have one quick comment, and it's actually to the lady's point who was asking about nutrition. Another member of the healthcare team that wasn't mentioned is an oncology registered dietitian. So anybody that's, if you're working with your physician and you're having a lot of nutrition issues, which as a dietitian I also did, and I had to reach out to another dietitian, please ask to be referred to an oncology dietitian.
Absolutely. I mean, I think there's a lot of team members. It's hard to list everybody. So there's even, financial management, case managers. The list goes on and on. Physical therapists. So big team.